Well, thank you very much. Thank all of you for coming here on the panel today. The insurance industry is often gets beaten up these days for all the alleged ills, but it's an industry that, as we all know, is going through a profound change. I'm old enough once upon a time to remember when it was just processing payments mostly, and then trying to figure out, is this procedure better than another procedure? But as you are going to be demonstrating, it's gone way, way beyond that. I'd like to start with Steve. You first describe an accident you had at West Point and how it changed your approach, bayonet accident, how it changed your approach to looking at patients and how to treat patients.
Sure. Well, so I was on a bayonet assault range, and turns out it's a bad idea to pass somebody else on that range, because the person in front of me slipped on some gravel and came around with his weapon, and I almost got out of the way. It would be a better story if that was maybe decided to be a doctor. The truth was, I knew I wanted to be a doctor from the time I was a little boy. It did give me a different perspective on what it's like to be a patient. And so something when I trained surgeons, I always told them is, it's not enough to care for your patient, you have to care about them. And I think that is what being a patient taught me. It's what I took into being a doctor, and it's what I have done throughout my career, whether it's been in the payer industry now, as a surgeon, as a policymaker, or as a teacher. That fundamental truth under being a doctor is why we're all here.
Say just one word about house calls, which I'm old
Sure.
enough to remember those.
Yeah. One of the things that I did throughout my career was make the occasional house call. That's not what you normally think of as a neurosurgeon. In fact, I take my kids along. If people needed stitches taken out on the weekend, they were anywhere nearby at all, it was easy enough for me to just stop by and see them. What a different perspective it gives you of both disease and treatment when you see somebody in their own home as opposed to your office. Now, you can't do that a lot, obviously. There's the efficiency of scale. But I really encourage the people I train to do that, to understand the human part of all of this. And it gets to some of that consumerism that you talked about and the importance of that, but also to not forget the heart of what we do.
In terms of bringing that to reality in the insurance industry, you've been one of the advocates of patient-centered care. Can you describe quickly the model you're pursuing, and then
Sure.
Also ACOs, how you see an ACO, how it's being affected by the Affordable Care Act in the real world?
Yeah, well, I think that really there's many important things going on around the Affordable Care Act, but maybe the most important is the energy it's given to transformation health reform. We've talked about it for many, many years, the need to reform our health system, that it's unsustainable. What the Affordable Care Act has done is actually made that talk have real energy and traction, and around a whole variety of things. For the health payer industry, we have a product that people like and increasingly can't afford. That's a problem for everyone. And so in the fee-for-service model, we can do things to slow down the rate of increase, but the incenting on volume is going to get volume. So we can't get to negative growth on health spend with the same outcomes in that model. So as an industry, if we don't have a more affordable product, somebody else will replace us. You've seen that in other industries, whether that's photography. You spoke about other industries today. We'll be replaced if we can't make that transition, and we should be. We won't be, because we are doing things around value of care, and everybody's looking for that one ring to rule them all. Is it ACO, is it bundled care, is it medical home, fee-for-service, HMO? The answer is yes. These are all components of a value care system. And what we need to do is refine those components. So we're doing that through a variety of pilots. We have, I still think, the largest private ACO in the country. We're doing medical homes, other things, to refine these components, to let them assemble in communities that make sense for that community. For instance, the idea that what will work in downtown Chicago, in rural Montana, or central Texas will be the same exact model, I don't think is realistic. I do think what you can do is create components that can be assembled into a value of care operation that can then actually get to quality outcomes at a more efficient cost because you're incenting efficiency of resource utilization to that outcome.
Can you just provide a quick example? We hear a lot about assessing the value of care,
Sure.
The whole patient. Give some just quick examples, whether it's Montana, Texas, or
Yeah.
wherever, where you've seen a substantial change from what had been done before to what the vision that you have now.
Yeah, a really specific example, we have basically an intensive medical home with one of our large groups. When we looked at that group, about 10% of their patients accounted for 60% of their health spend. I'm not a genius, but I might start there. You know, and so we put an intensive medical home around that reduced that group's overall health spend by 20%. You know, 20% is a big number. It's not 2%, 3%. It's a real number. And also decreased lost work days, improved productivity. That's a model that that anyone would want to emulate and expand through the system. We've had success in our initial iterations of ACO, but like initial iterations of everything, you learn more than you achieve. And so we're proud of what we've achieved, but we've learned an awful lot that we would like to use to refine that model and help everyone involved, because in a value, in a shared risk value care model, it only works if both the providers, payers, and in the end, consumers succeed.
Doug, you've been a pioneer as well at IBC of working in terms of trying to do a whole approach instead of the piecemeal approach. Quality performance standards. You've had several years of experience. Can you share with us some examples of how you turn a nice concept, quality performance standards, into something real?
Sure. Yeah, we, independents really embraced the whole accountable care concept even before CMS came out with their plans. We put together what would best be described as an ACO payment model a couple of years ago because we recognized that we were in one of the highest cost markets, and most of that high cost was driven by very high levels of utilization, among the highest in the country. And so we put together what we thought was a balanced model incentivizing improved quality and reduced cost. And we tried to address some of the historical deficiencies that had existed among those programs. One of them was the lack of inclusion of specialists. The second had to do with ensuring that the incentives and that the program value was substantial enough to get the attention of the doctors and the hospitals who were participating. And so we put together this model, and over the past couple of years, we've actually been able to deploy this accountable care model across about 85% of our network in the greater Philadelphia area. So essentially, this model now touches about 30,000 providers. So the good news is the incentives have been aligned. We've also partnered with a company called Lumeris, who has been very helpful in helping us provide the technology piece, some of the tools that are necessary. These tools have been very useful because they actually allow you to pair clinical data, EMR information, with claims data or financial information. And historically, that has been a big gap in our industry, because if you're on the provider side, you saw the clinical view. If you were on the insurance side, you saw the claims view. So, at this point, I think we have a good program. I think we have the good technology to support it. But the biggest challenge really is behavioral modification, because it's very difficult to achieve process transformation and really get physicians in particular to change the way they do things, not simply rely on old referral habits and old ways of seeing patients and following up on treatment. And care coordination is a huge component of that too, because the healthcare industry has been extremely siloed over the years, and the primary care physician looks at his or her piece, the specialist looks at his or her piece, the hospital, they have their own area of focus, and trying to get that, as I say, behavioral modification to stick and to get these different components to work together really is the key to success.
So you've been a catalyst in this, but making it happen. Many parts of the country, hospitals seem to dictate to insurers, not the other way around. How are you able to change that power balance so you get them moving in a direction that you
Well, I
think
think,
is...
yeah, I mean, that's a very good point. And I think, one of my observations over the years is that physician engagement is really the key. When you have a hospital-dominated market, and a lot of markets are like that, you have to be willing to do some controversial things to really affect medical delivery transformation. And one of those is physician empowerment. And I think once you are able to do that, and once the doctors, particularly the primary care physicians, have a seat at the table and are able to guide the process, you increase your chances of success tremendously. And I think that really has been our focus.
The ACA, how is that? Because you were doing this before ACA really started to become effective. How is that affecting you? Is it helping,
Well, I
hurting,
think,
or complicating?
No, it really has helped because this type of provider integration and payer-provider integration is something that I have personally been advocating for the past 25 years. The challenge in the past is that there hasn't really been a reason for providers to engage to the degree that they have today, because now you have the momentum that I think was fueled by CMS and the accountable care organizations, Medicare shared savings programs. You also have healthcare purchasers who are taking some pretty strong positions on what they want to see. One of our big customers in Philadelphia is Comcast. And Comcast has said, look, over the next couple of years, we want to trim 30-40% off of our healthcare expenses. But we don't want to weaken the employees' benefits. And we want to see some real engagement and involvement on behalf of the providers. What are you going to do for us? And so having that kind of backing really is very helpful, I think, if you're in this business of healthcare transformation.
Gail, you've been a pioneer in what you call intentional integration and pushing for that kind of change. And United has been noted for its emphasis on data, big data, what you can learn from it, how you get people to change. How have you been able to push this forward? What have you learned from the data, and how do you get people like me to behave ourselves? We're a client, so I know you try to get us to eat more healthily and
We
do
do
things
try.
I'm not normally prone to do.
So, I think the conversation we're having is around two transformational themes this morning. One is the role of the consumer and the emerging transparency, consumer tools, engagement, incentives, and the second is around the transformation of the delivery system. And let me touch on both, because our view on this, and I think the benefit that we have is we are a big participant across all sectors of healthcare, from Medicare, Medicaid, commercial, the individual market, and then our services company, Optum, works very closely with the delivery system to help them transform. So data for us is really a way to help engage both parties to make better decisions and I think integrate the process better. So from the consumer perspective, I think it does start with transparency and the alignment of the design of the program. So the plan design, and we like to think about, what are the incentives for consumers to get more engaged in their health? And you can do this even in Medicaid. It doesn't have to necessarily be a cost sharing. It can be based on incentives for gift cards and health and wellness, and we already see that with our Medicaid population and getting moms to go to their obstetrician but when they're pregnant, and an improvement in visits. And then
Are there certain states that are ahead of others in terms of?
So we've done this in many states. We've done it in Maryland, for example, where we rolled this program out. In Tennessee, we work with 25 different states in Medicaid, and we've seen a fairly across-the-board improvement from our commercial book of business. We see a lot of engagements. We have 6 million people in consumer plans and over 1 million in this incentive rewards. And what that does, so on the intentional integration, what you really are seeing is consumers have much more incentive in the game to eat healthy, earn rewards, follow their health, get their screenings. And then we have an opportunity to engage them with the system. So that's the first part of it. The second part, I think it's about everything we've just discussed, is how do we change from a fee-for-service fee-for-service payment methodology with the delivery system to one that actually incents for better outcomes. And we know in the statistics that were shared that 5% of the population drives about 50% of the costs. So you're really dealing with two sectors. One, the well and keeping them active, helping them understand how to stay in the system and getting ahead. And those who are dealing with multiple chronic conditions that we need to basically incent the system to work better. And we as payers, I think, change our clinical models to provide the right data and to provide the right incentives for them to be able to practice in a population health methodology. So I think when we think of this integration, the pieces have to come together, and that's where you get the best bang for the buck. And the opportunity is for us to do that on both sides. And so as we talked about the accountable care, our view is, that healthcare is intimately local. And so the structure of the way you work with the delivery system varies based on the structure of that market. So it may be gain sharing arrangements, it may be full accountable care organizations, it may be capitation in certain markets where they're very sophisticated. But we need to engage the delivery system in managing the full population and pay them where they are in the process. And so we see it as a journey. And from our perspective, we've got about $25 billion of costs going through all of value-based payment, and our goal is to get to $50 billion so that it is a fundamentally different way of practicing.
When you came to United, you made the point that a policy that worked, say, in Florida would not work in California. Can you just quickly give an example of just how diverse this market is and address the question that people fear that as we try to get the patient to do better things, it's sort of going to be a one-size-fits-all, and if you don't fit in a certain box, even though each body is different, same but different, it's going to be more cookie-cutter rather than the kind of personalized care that we want and technology seems to promise.
Right. So, even a few years ago, we said that the structure, so it starts with the structure of the healthcare market, I think, and whether it's hospital-dominated, large integrated physician practices. So how we work with that delivery system varies. And again, it's this continuum of if physicians are practicing pretty much a non-integrated, we may go with incentives to work with the physician to close gaps in care. If it's an integrated, fully integrated system, we may think that it's the best way to work with them as an accountable care organization because they have the ability to manage, to change the way they practice and actually manage the population of patients. From the consumer perspective, the one beautiful thing is data allows us to segment the population and build products that are unique to that marketplace. And so while there's a framework of different things we can do, we're able to understand who the best performing physicians are in that marketplace, structure products around them, and then use our tools. So our tools may be very similar. Your ability to go online and look at cost, quality, and efficiency, incentive programs to help you engage in a healthier lifestyle, get your biometric screening, earn incentives. But the structure of the product will fit very much to the way that we're working with the delivery system, and then you'll have choices as individuals. So I think, quite frankly, the role of consumerism in many ways changes and improves the choices, and people have greater transparency, and there's less secrecy about cost, quality, and choices for consumers. So I actually think that will accelerate a lot of the things we're talking about with the delivery system as well. And so very different in Florida, where Chicago is a very hospital-centric market. Florida is much more dispersed. I'll give you one example. We're working in a community which is predominantly retirement, called the Villages.
Right.
Heavily Medicare-based, and so the structure of that is people live in the community, they commute based on golf carts. They're essentially, all of their services are there, and we're working very distinctly with products in those clinics to help support them in their local communities versus Chicago, which is much more dispersed, and people aren't living in those kind of geographic communities. So our products can support that with tools and incentives. That would be one example.
Right. Bruce, I mentioned your name, I hope not in vain, about the biking accident, and just as Steve saw firsthand from his bayonet accident, you saw firsthand a little over a year ago in terms of how siloed this system is. And what could you describe it, and what did you learn from it?
Well, I saw, being a customer, what we're doing to our customers, and I think the silos in the healthcare delivery system creates an experience that is just uncalled for. And as you mentioned in your opening remarks, that I had to fill out multiple forms and had to go through this process that was more painful than the actual injury itself and that aspect. And I think, as we think about healthcare, I'm excited about the future. I think the future is moving from talking about sick care to moving to health. And I think as we move to that, it is, as Gail was saying, it really requires two fundamental changes. One is around how are the providers engaging in the system? And I think as they move more around value-based payments, that will move their discussion more to health, to worry more about individuals' health.
Let me just ask you, since you're involved with the government in a major way, especially in Medicare. Medicare Advantage is almost over 60% of your business. How do you avoid the trap of where, as you're facing pressure, they are cutting your reimbursement rates?
Right.
How do you get from productivity, where you get more for a dollar,
right,
to where they just need to cut it, and they're going to cut it, and it affects care, and we end up with rationing?
Yeah. Well, we have been since really the the ACA started, we've been under constant pressures, as Gail has been in her business, on a reduction in rates. And really how you make a business model out of that and continue to be successful is you have to be more efficient. And really there's multiple ways to be efficient. Obviously, as one is on the administrative side, but the second is continuing to help people be much more efficient through the delivery system in that regard. And we've talked about it in different ways. We've talked about it on, I think Gail articulated it well, around first you have to get the delivery system more engaged in care. And I think this transformation from fee-for-service to value-based payments is where we're going to be. Today, about 30% of our members are under relationships that are actually value-based reimbursement. So their physicians have a relationship with us that they are focused on how both quality and cost is part of the healthcare delivery system. The second part is around this consumer side, as Gail mentioned, around the engagement of health. And we find no matter if you have diabetes to you are a young, healthy individual, engaging with them around their health, and it's not a transactional relationship. It's a relationship that begins to have a meaning to them over a long period of time. Our Medicare Advantage members are with us 7 years to 10 years, so we have a long relationship with them, and we get paid a fixed fee, and so we are very, very engaged in their health and that. I'll just say one thing that I think highlights it well is I received a letter a number of months ago from a member, and the member, 2 Medicare Advantage members, articulated that they thanked us for enrolling them in silver sneakers. They thanked them for us sending a doctor to their home, because we send doctors to their home. They thanked us for reminding them about their ammonia shots. They thanked us for all the preventative care that we're providing them. They didn't say one thing about insurance. And when you think about the transformation for insurance, I think we have a wonderful opportunity to move to that engagement around health.
Let me ask you a rude question. Does Washington like Medicare Advantage, or do they have you in the crosshairs? Because you're not under one tent.
Yeah, that has changed for a few reasons, and one reason is the fact that the rates have come down since 2010. Today we are being reimbursed at about Medicare rates, so the equivalent is becoming more equivalent in reimbursement. And then the second aspect is the program has matured, and it's demonstrating both quality, and so we have a stars rating, and you're seeing the quality of the program increase, and the cost is becoming much more effective. And I think this year, as they began to change the rates, the initial discussion around what rates were, and then the subsequent discussion really proves that they are committed to it. On top of that, Steve, almost 30% of the Medicare population is in Medicare Advantage today, so that's a big voting pool that goes with that.
That's always a good insurance policy. Before getting to the audience, let me just ask each of you just a general question, and that is employers may be, given the new circumstances, in effect pushing employees out into the individual market, out into the exchanges. How's that going to change the insurance business? Are we going to get more to an individual business rather than employer-provided insurance? How do you see that playing out, and how do you adjust your environment for it? Why don't we start with you, Gail?
So, I mean, I think the dominant theme, why that question keeps getting asked, is affordable products. So our focus on, we need to continue to evolve our product structure, and we need to get focused on individual consumers and ensure that we demonstrate value. So it goes back to those two things. One, the construct of how consumers find value in products, and secondarily, the underlying cost structure, which is essentially the transformation of healthcare that we've all been talking about. I think the way we think about it, that there will be a bigger consumer market as you look at what's going on in exchanges, that is a significant market. The subsidies are significant. Much heavily in the individual market. We don't see a significant amount of dumping into the individual market right now. We actually see that as muted, but clearly the underlying driver is affordability and cost for employers, and that's the focus across the largest employers in the space all the way down to the smallest. So I think our model is very much evolving around being able first to work on the delivery side, but secondarily to be a very consumer-focused enterprise, and our products have to demonstrate that unique value. So that's really how we're thinking about it. And we have a very, very strong footprint across the market. So our Medicare market, great example, it's the largest consumer market we have. People select every single year. The retention in that market is significant. So we have a lot of insight into that. And quite frankly, our insight into the Medicaid market is important, because just because you're in the individual market today, your financial status changes, and people will not be in the traditional buckets that we've historically thought about them in. You know, an individual product, small group Medicaid, they will move in terms of their status over time. So we are thinking about them holistically. How do you form a relationship with a consumer because of the attachment to health over time? And that's a really important thing, and we've got obviously some insights into that given the work that we do across those populations.
Bruce?
Yeah, we believe the closer you get it to the consumer, the more effective it'll be, and both on the decision of how health is decided, and then secondarily the purchasing side. And so we believe exchanges are a great opportunity for that and engaging with them. We think employers
Both
will
the state exchanges and these private exchanges.
private
that are coming
exchanges
up.
and that.
Yeah.
And then again, it's what happened to 401ks versus
Right.
the retirement program years ago. And people become more interested in it as opposed to someone making a decision saying what it is. And so we believe consumerism, and I feel like I'm repeating what Gail said, is upon us in healthcare. And we think the consumer, that's a great opportunity for everyone, including the individual themselves, because they can customize it. They can pick the program they want. They don't have to rely on their HR department to do it, so to speak. And it's for them. In addition, there's now a true engagement with that individual, not going through as much the employer, but going through the individual themselves. And we think that will have a large impact on both their engagement in their health, but also subsequently the health outcomes that's there.
Doug?
I would agree with both Bruce and Gail. I mean, really, it is a transformative time, and from an insurer standpoint, it becomes more of a retail play, and that isn't something that we've done that much of. Most of the business that large commercial insurers have comes from big national accounts, large groups, and
Comcast.
Comcast, and we've done a very good job trying to forge relationships with insurance brokers, insurance consultants, and employee benefit managers connected with these larger companies. Selling directly to an individual is something that we really only dabbled in through products like Medicare Advantage. So it requires some change on our part.
Steve?
Yeah, I think business is going to do what makes sense for business. And in some cases, that's going to be to maintain the current group employment model that has worked very successfully for them to retain and attract talent. Sometimes I think some will no doubt in the future look and say it makes more sense for us to move to a defined contribution model and into a private exchange. And so I think that is going to be a growing piece of this that'll make sense for some. And that empowerment of the consumer as my colleagues have said, really will help us create specific products, leverage data. It also, the engagement of the consumer changes how we use data, because there is a need for us to share information with the consumer in ways we never have before. In traditional contractual arrangements, data is power. And in a traditional contractual negotiation, you hang on to it. Once you start to have a different engagement with your consumers, in our case members, we're member-owned, there's a need to share data, not just a desire. When you create a rational business need to do that, that's very transformative. The last thing I wanted to say was, I am struck sitting here. You have 4 different payers represented, large payers, all saying the same thing. And that's striking to me, because we just met minutes before this, and you hear this change from fee-for-service to value. It's an absolute need for us and for everyone else to do. This need to engage in increasing consumer-driven market, this need to share information in new ways. Hearing that same thing over and over again, there may be something to that.
Wow. Questions, as you know, please raise your hand, state your name and organization.
Hi. Is it on? Aya Khalil with GNS Healthcare. So it strikes me as we're having the discussion about how we move from fee-for-service to pay-for-performance that we are, I would say, currently lacking the systems in place to appropriately measure, track, predict outcomes for patients, and actually have that learning feedback loops. And so I'd like to hear from you. What is it going to take for us to get there? What are the enabling technologies? Who needs to make these changes? Because these are big changes that we have to make.
I'll start out. I mean, I think we all have different data systems. We have made a conscious effort in investing in the integration of both claims-based and electronic data together with predictive modeling that helps in navigating through the health system. And so, we acquired a company a few years ago called Envita Health out of San Diego, which really is taking the electronic data and bringing it together to form opinions around what the member needs, and then being able to bring that to the member as they are needed. Second aspect of that is also we have been in Medicare Advantage a long time, and Medicare Advantage, especially in Florida, has been wrapped around a risk relationship with providers that provides them insights into how they are performing under risk relationships. We have scaled that now, and that's across the country, and that has allowed now providers to be not what it was in the early 90s, where they were taking risk, but they didn't know what they were taking. Now we are seeing a much more effective decisions around how they are taking that risk on and then being able to manage through it, and then making the effective decisions around the care. The last thing I'll say is the data is reducing utilization in the healthcare system, but I think the care is getting better. And it's getting better because I think we're much more insightful around what is needed, as opposed to maybe a little more of a broader delivery model that doesn't have the data to be able to make that decision.
So I'd love to join in on that conversation, because I think actually we do have the data. And I think we are, I think the challenge we've had is integrating it with the care provider systems themselves. So we actually can now identify every gap in care for every member in that practice. We're sharing that information with our physicians. We're sharing it with our hospitals. Most of our contracts are based on pay for value and improvement in very specific measures. We have been tracking something called premium designation across our physicians for many years, and can show differences in cost, quality, access. So I think the data exists. I think what is changing now is the integration of the plan design, so that there's more consumer interest in this, as well as the clinical models. And the last point I'd make, I don't think it's just about the medical system. As we think about what's happening with these population of patients and individuals coming into the system, it's medical is really important, but social and behavioral issues are equally as important. And so we have been working something that focuses on, we call Healthier Lives, the virtual integration of medical, behavioral, and social. And as you think about social, people's access to food and housing and access to care, how those interrelate to many of these populations is as important. So the combination of that data in a unique way to deal with the patients personal situation and their caregiver, to me, is the next opportunity to really change outcomes and the trajectory of care.
And it's the ability to not only assimilate and share data, but how do we assimilate it? I think one of the things that high tech did was created an incentive to get some of that critical infrastructure that's going to be needed to do value-based reimbursement. And how do you help physicians understand their patients more effectively at a more granular level? How do we then merge that data with the data that the payers hold? And then provide that to consumers in some cases. A open standard, blue button is something that can allow the consumer to be the aggregation point of their information and decide how to use and reuse that to incorporate social applications, new technology to help them manage their health as well as their health care. So I think if we get the incentives right, we will create a dynamic business, series of business models under it, frankly, that we can't really imagine. That's why you just want to get the incentives right and let this iteratively carry out through business, because who would have predicted, other than Steve Jobs, a decade ago, what an iPhone would look like and how it would change our lives? We're there in healthcare. If we set the right incentives, we can create an industry that we actually can't imagine, and we'll get to iteratively. And I agree with Bruce. It's going to be a much more efficient and much better experience for the consumer and all of us in this industry.
Oh, right, yeah.
Chuck Denham, Chair at TMIT, also on faculty at Mayo Clinic and at Harvard. And we have a research testbed of about 3,100 hospitals. I'm the editor-in-chief of the Journal of Patient Safety, and so we kind of see from the inside there's an amazing disruption going on. Profit centers are turning into cost centers are turning into profit centers for the providers, and there's enormous stress on them. I think we all think that the power of the consumer is going to be awesome, but the low-hanging fruit right now is price point, not the quality and tying the quality to real value. We've got probably a misdiagnosis rate, for instance, in cancer of 10 to 20% at the front line. Total misdiagnosis, overuse probably 30 to 40%, and the pendulum swinging the other way so rapidly that we really have a risk of commoditizing and going to the lowest price, chasing the lowest price a la carte to the bottom, and not bundling the care in a set of processes that our great centers can really deliver, but perhaps the front line can't when you're going a la carte. How will we, and when do you see the informed consumer really being empowered to really see verification of the value that they're really getting? We developed a survey for Leapfrog and the verification for their CPOE system, and that's going to be the lagging 2 or 3 years lag.
Yeah, I couldn't agree with you more. Value is the key, and to your point, value isn't price. Value is combination of cost and outcomes. And even though we do have quite a bit more data today than we used to, we still have some major deficiencies. And I'll give you an example. In most states, hospitals do self-report many quality indicators, and that has helped us quite a bit. In a lot of states also, you have access to HEDIS and other databases that give you some indication as to how well primary care physicians are performing. But I think the huge gap is really on the specialist side, because there is no central database on how urologists compare, or how orthopedic surgeons or gastroenterologists or general surgeons compare in terms of outcomes, because nobody's feeding any database in any organized fashion. And so until we address that gap, it's going to be very difficult to put together meaningful outcome information for specialists, which probably represent 90% of the physician providers across the country. So that is a huge gap today. And so I think what most payers have done is we've taken what is available, we've done the best we can to the extent we can point to publicly reported quality information and use that information in developing programs or tiered networks or limited networks. We do that, but we can only use what's out there, and to the extent there are deficiencies, which there are, we have to work around that.
Well, that's the whole thing of getting to value, and it requires a partnership. And so you're right, we have great transparency now on cost, and it will only get better. That's only half the equation. You have to have that other half. As payers, we can't do that ourselves. CMS can't do that ourselves. We have to partner with physicians. I'm looking eyeball to eyeball with a couple of colleagues here, that we are committed to working with physicians to help us develop better and more relevant quality and outcome data that then we can share, that we agree makes sense, is a fair comparison. Then you can really get to that, what you're talking about. That's one of the most exciting things going on here.
Sue Hellman from University of California, San Francisco. This is a remarkably polite conversation with words like transparency and sharing, but data is power, and data on your claims data is, I've always thought of it as something that is part of your business model, that using that data and your unique insights into that data is part of being an insurer. So I want to drill down a little bit more on the sharing that's been discussed and the transparency, because I think both for public health and innovation reasons, you have a goldmine of data, and particularly as you connect claims data to electronic health records. So in a meaningful way, are you really willing to share data or only share some data? And how do you balance the appropriate business need to have your claims data be part of your company and part of your unique value add with the more public good? So have you had dialogue about sharing your data, pooling your data, or even selling your data? And what do you consider proprietary and a business interest of your company versus sharing for the public good?
Gail, why don't you?
So I think there's a whole lot of questions in there. So let me, that was a very broad set of, data. So let me start from the consumer part of data. So we had the conversation a few minutes ago. That data is out there. You can go on today and figure out the exact cost and quality indicators and look at the complete treatment episode of care against your plan and know exactly what it's going to be. So that transparency exists. It needs greater use. So that data is out there, and it's pre-adjudicated claims, so it's fee schedule-based data. So there is no, we're trying to take away any of the mystery. So that veil has been broken. I think one of the challenges, quite frankly, in the past was agreement with the delivery system to have that out in the marketplace. But that now, I think, is past history, and it is out there, and consumers have access to all of that. I think the comments about quality are really important because right now we have been profiling, quality, readmission rates, issues that occur, and so we have a rating system, but it's based on very deep data and longitudinal data. So from the consumer perspective, that's out. I think what has also changed is when we are entering into accountable care relationships, where you're basically attributing patients and managed populations, we're absolutely sharing data. I will tell you, we are sharing data with all of our physicians on each of our patients that are in their office to help close gaps of care at the individual level and how their practice is participating. At a broader sharing of data, actually, I see Paul Bleachers here who runs our Optum Labs. We're actually in a consortium with a multitude of players to actually look at the big questions in healthcare and research, and that data is a combined asset to solve big problems in healthcare. So I think that has completely changed. But I also think we have to be respectful of making sure the data gets used appropriately. And so I think that we're in an evolving sense of that data, but it is a much more open to solve the issues of healthcare as we work with delivery systems. Clearly, that's the only way we can change the dynamic of the practice pattern behavior inside of what the physicians are doing, as well as how we change the reimbursement structure. So I think it's evolving, but there's a much greater view of sharing data. And I would say, I don't think data itself, the old world, what ACA has changed, the old world of underwriting is gone in the sense of today. So we're competing on very different grounds. We need a partnership with the delivery system. So I think that's why you're hearing a very different conversation, because we're not going to be able to create product and change the world. We need to basically be able to work with the delivery system in a very unique relationship. We are both at risk for the overall cost of care.
Well, unfortunately, we've run out of time. This is obviously a very key topic, and thankfully our panel participants will be here during the day, so you can get them during the breaks and during the meals and ask the questions you didn't get a chance to ask. And let's thank them very much. And what's amazing is how things are changing in this turbulent environment in a way who could have imagined it 10 years ago. Thank you very much.
Thank you.
Thank you.